Welcome to Shiv Shastri's podcasts. It took me 5 years to learn how to operate. It took me 10 years to learn when to operate. But it took me 20 years to learn when not to operate. A good friend of mine, a neurosurgeon, once told me this, and it is so true. As young trainee surgeons, we were limited in the number and variety of operations that we would be allowed to perform. As we gained experience, we all vied with each other to pick out patients with diseases that need surgery. In my medical college, JIPMER in Pondicherry, there used to be 3 surgical units, each headed by a professor. Each unit would spend 1 day treating outpatients and admitting those who needed surgery. We would assess them in a grand ward round the next day, and those who needed surgery would be operated upon on the third day. In my second year of surgical training, I was jealous that my mates had all done their first thyroid operation and I had not done one. One day I found a young lady with a swollen thyroid gland and got her admitted with the intention of operating on her. Of course, my plan would need to get past the professor in his rounds the next day. Come Thursday morning, I eagerly finished my own rounds, checking each patient and recording their progress, and waited for the professor to come round to the patient I had admitted. The rounds went painfully slowly. Intensive care first, male ward next, and finally the women's ward. This was going to be my big day. The professor came up to the patient I had admitted with my planned assault on her thyroid, took one glance at her and asked, "Who admitted this patient?" Proud as a peacock, I stepped forward and said, "I did, sir." My heart was racing. I was going to be a big surgeon doing big operations. The professor's face was not very encouraging. He asked me, "When did this lady have her last menstrual period?" My heart sank. My knife-happy mind had blanked everything out. I had not asked her, but did so there and then, ashamedly, in front of my seniors and juniors. Her last period had been 4 months previously. She was pregnant. Pregnant women and young adolescent girls often get an enlarged thyroid gland. This is perfectly normal. Like a lowly worm, I had been planning to operate on the normal thyroid gland of a pregnant woman. My plan was shot down and my ego shattered. The lady was sent home there and then, and I did not get my thyroid experience until the following year. A decision not to operate on somebody can be a critical one, as happened to me decades later when I was an experienced surgeon. I had a critically ill 65-year-old man under my care. He had something serious going on in his abdomen or belly, which would definitely warrant surgery in a younger, fitter patient. This was in the days before laparoscopic keyhole surgery, which would allow us to peep into the abdomen without making a huge cut. That huge cut makes a difference. After an operation on the abdomen, a patient does not breathe so deeply because of pain. And when he does not breathe deeply, his lungs do not fill fully with air and they can get infected. If the lungs get infected, the patient gets less oxygen than he needs and he develops a cough. But he cannot cough because of pain, and when he cannot cough, he cannot clear his lungs to allow him to breathe better. Most young, healthy patients do not have such severe issues, but a senior citizen with associated problems like diabetes, asthma, or heart disease are at increased risk. My patient had everything. His belly was in a bad shape, needing an operation, but he had damaged lungs from smoking, he had diabetes, and he had a poorly functioning heart from several heart attacks. In fact, his heart was in such bad shape that merely putting him under anesthesia could have endangered his life. This is always a dilemma for a surgeon. The call to operate on such a patient needs to be taken with full consent that the operation may be the last event in the patient's life. On the other hand, not operating in time would be an act of wasting the only chance one has to save a life. I weighed my options and decided that it would be worth attempting treatment without surgery for a day or two, and that if he failed to improve, I could take another call about performing an operation. I had a long discussion with the patient's relatives and commenced treatment. Nothing much had happened by the end of the first day. On the second day again, I found no improvement. The treatment just did not seem to be working. On the evening of the same day, I checked on the man again and found no change. Everything that had been wrong continued to be wrong. His belly was swollen and tender all over. His weak heart was pumping as furiously as it could. His blood counts were all telling me to enter his abdomen and clean it up. I decided to take him up for surgery the next morning and once again discuss the risks with everyone involved. The next day I started early with some anxiety in my mind, knowing that I might contribute to ending a man's life later that morning. While driving to the hospital, I stopped at a red light and looked around. On my right was a specially abled man on a scooter that was modified to act as a motorized wheelchair suitable for road use. When the light turned green, I moved forward and suddenly, out of the corner of my eye, I saw an auto rickshaw careening past the specially abled man, brushing his vehicle and knocking it over. The helpless man spilled onto the ground, prone. The auto rickshaw driver accelerated to make a quick getaway. Something snapped inside me. I jammed the accelerator down and cut off the auto rickshaw with my car. I was young and strong then, full of fire. I got out and pulled the auto rickshaw driver back to the scene of the accident. A crowd had collected. Fortunately, there was no serious damage to the man or vehicle. I let the crowd sort out the settlement between the auto driver and the man he had knocked down. I then drove to the hospital. Somehow my tension, my feeling of foreboding had gone. Despite the incident on the road, I was early. I changed into scrubs and went to examine my patient one last time before starting the operation, as is my wont. To my utter surprise, his belly had, literally overnight, become soft and without pain. His furiously racing heart had slowed down to a more sedate pace. This was no longer looking like a man who needed an operation. I decided to postpone surgery and sent the man back to his hospital bed. For reasons that I cannot explain, the man continued to improve, and I let him go home a few days later. If there is a God, that God was hovering above me and the patient that day.